Hi everybody! I hope by now that you've all watched and listened to Chapter 33 and have a basic concept of everything that was in that chapter. Hope you looked over the drugs, the procedures, and listened to the 4 YouTubes that I asked you to listen to. Now, before I move on to Chapter 34, I would like to go over the NCLEX questions at the end of Chapter 33. So if you get your book, which we're going to need for Chapter 34 anyway, so if you get that book and go to the NCLEX questions, it's on page 637. So the answer to number 1 is 4. The answer to number 2 is 2, capillary. The answer number 3 is 3, emboli. The answer to number 4 is intermittent claudication. Answer to number 5 is 4, 2 plus edema, both ankles. Answer to number 6 is 3, angiography. Answers to number 7 is 1, exercise, 2, elastic stockings, 4, elevation of extremities, and 5, smoking cessation therapy. Number 6, the answers are number 1, number 2, number 3, and number 4. The answer to number 9 is 3. The answer to number 10 is SA node. The answer to number 11 is number 1. The answer to number 12 is 3. Answer to number 13 is yes. Answer to number 14 is 4. Answer to number 15 is 3 and 5. And the answer to number 16 is 2, 4, and 5. Alrighty, so please look that over. Be sure you understand 33 because everything you learn in 33 we're going to start applying in Chapter 34. So let's get started. So first we're going to talk about coronary artery disease, and that is referred to ischemic heart disease. Arterial sclerosis is an abnormal thickening or hardening and loss of elasticity of arterial walls. Atherosclerosis is what we basically want to talk about, and that is an inflammatory disease that begins with endothelial injury and progresses to the complicated lesion seen in advanced stages of the disease process. Now, the thing about atherosclerosis is it builds up plaque, and that's on the next page, 640. So you build up that fibrous plaques, and those fibrous plaques begin to trap substances. So under fibrous plaques, it says this process forms a fibrous plaque that protrudes from the wall of the artery into the lumen, or the hole in the artery. Other substances, white blood cells, platelets, lipids, calcium, adhere to and collect within the plaque. So you can see that plaque will build up and eventually might occlude. So signs and symptoms of angina or coronary heart disease. Angina or chest pain is the most common symptom of coronary heart disease, and that results when the demands for oxygen by the myocardial cells exceeds the supply. So the demand, you're doing something, exercising, the demand of the heart, the oxygen of the heart is not enough to what you need for the heart is what delivered to the heart. So there's 3 types of angina. I'm going to talk about that in the next slides. So let me just go on to diagnostic tests for a minute. So these are things you learned in the previous chapter. So tests used for the diagnosis of cardiac disease are EKG, Holter monitor, implantable loop monitor, echocardiogram, TEE, stress test, MRI, and possibly a MUGA, which is a multiple acquisition scanning. Also some labs that would be done, ABG, your blood gases, the CBC, BNP, and C-reactive protein, or CRP. So the BNP stands for B-type natriuretic peptide, was something that shows in congestive heart failure. Right, medical treatment, diet therapy, drug therapy, and reduction of modifiable risk factors like smoking, overweight and obesity, and high blood pressure. 3 classes of drugs are used for medical treatment: beta blockers, calcium channel blockers, and nitrates. In addition, all patients with angina in the absence of contraindication should take low-dose aspirin daily, as this is shown to inhibit platelet aggregation and reduce for overall risk of MI. So where that plaque forms, notice there were some blood cells that platelets that would fill that area in. So on an aspirin, it will help keep the flow going through that fibrous plaque area. ACE inhibitors may be prescribed to patients with stable angina to reduce the risk of an MI. And also some other things would be angioplasty, stent placement, or atherectomy. Now I will go through some of those as we go along. Surgical intervention will also be discussed later in this chapter. So let's move on to the angina I promised you. So the first angina, there's 3 types of angina. The first one is stable angina. So if you want to go back to the angina area on page 640, that's fine, because this is where I'm going to be talking about. So stable angina is chest pain that occurs with exercise or activity. It can last 2 to 5 minutes, but it subsides with rest or nitroglycerin. Usually take 3 nitroglycerins from the bottle, and hopefully that will relieve the chest pain. Also, smoking, physical exertion, emotional stress, and heavy lifting can bring on this angina. Pain is described as substernal squeezing, and sometimes it radiates down the arm or the shoulder, up the neck, or into the epigastrium. Patient may also exhibit diaphoresis and dyspnea or shortness of breath. Next angina is unstable angina. Now it's important that you understand about unstable angina because it's severe. It occurs at rest or minimal exertion, and it is not relieved with nitroglycerin. The symptoms are dyspnea, shortness of breath, diaphoresis, sweating, nausea, and vomiting. These patients with unstable angina are at higher risk for MI that nitroglycerin has not relieved. Nitroglycerin vasodilator, dilating those coronary arteries, hasn't worked. So they're more at risk for myocardial injury. And then there's another kind of angina called Prinzmetal angina, and that is just a coronary artery spasm. Oh, it can still cause pain because a spasm, like when you get a spasm in your leg or your arm, it hurts, doesn't it? But it's just a spasm and it goes away. So Prinzmetal angina is unpredictable and usually occurs at rest. The treatment is calcium channel blockers to prevent the spasm. It's not life-threatening. So some medical treatment, like I was saying, diet therapy, Drug therapy, beta blockers, calcium channels. Yes, indeed, I'm repeating myself. Nitrates. So transdermal. Nitrates can be given different ways. And remember, nitrate is a vasodilator. Can be given transdermal like a patch, be given orally or sublingually, topically, or it can be a spray. That can be a spray under the tongue as well. Low-dose aspirin daily to inhibit platelet aggregation and reduce the risk of MI. You want to have risk reduction, and in other words, reduce those modifiable factors that you can reduce, and get a yearly flu vaccine. That's important. So let's talk a little bit about myocardial infarction. So within 24 hours after an infarction, the healing process begins. But what is a myocardial infarction? It's the death of myocardial tissue caused by a prolonged lack, a prolonged lack of blood and oxygen supply. The average age for men having a first heart attack is 65, and the average age for women having a first heart attack is 71. But I know it's becoming a little more common in women, but they present differently. Their pain is different. Risk factors: overweight, obesity, smoking, high-fat diet, hypertension, family history and gender, male gender, diabetes, physical activity, and excessive stress. Smoking, a high-fat diet, hypertension, physical activity, and stress are considered modifiable risks, something that you can do about them. Pathophysiology. Sorry about that. Okay, let's go to risk factors again. Overweight and obesity, high-fat diet, hypertension, family history, male gender, diabetes, physical inactivity, excessive stress. That's how I feel right now. Modifiable risk factors are smoking. These are things you can change. Quit smoking. Adapt or change your diet. Make it more low-fat. Manage your hypertension. Take your medicines. Regularly exercise. And stress reduction. And that could be meditation, it could be running, something that reduces your stress level. So the pathophysiology, an MI begins with coronary occlusion. So that fibrous plaque gets occluded and the blood flow is stopped to the heart through the coronary artery. Could be just one. You've got multiple coronary arteries, but one might be blocked. Over 4 to 6 hours, ischemia or a lack of blood and oxygen, and the infarction develops. Ischemia can last 20 minutes or longer, but can have irreversible damage. After 24 hours after the infarction, healing can begin, and by the 3rd day, necrotic tissue is broken down and removed by macrophages, so they come and eat up the necrotic tissue. So there's 2 types of MIs. One is called a NSTEMI, non-ST elevation MI. It's usually transient or partial occlusion of a coronary artery. A STEMI MI is total occlusion of a coronary artery. So some complications that can occur with an MI would be dysrhythmias, some disturbance in the heart rhythm, rapid, slow, irregular heartbeats, or heart failure. The MI can cause the heart to fail as a pump. If the injured ventricle is unable to meet the body's circulatory demands, the ventricle fails to empty efficiently, which can increased preload, leading to systemic and pulmonary edema. Cardiogenic shock can occur. It's the most frequent cause of death after an MI. It's related to occlusive injury to the left ventricle and is more common than when the patient has had a previous infarction. Cardiogenic shock is presented as hypotension, skin is cool, moist, oliguria, no urine output because the heart is failing right side, left side, right heart-sided failure. Sometimes the kidneys stop working or decrease working, and decreasing alertness. Thromboembolism may form in the injured heart chambers or in the veins of the legs, and the thrombi can get loose and travel through the circulation, embed in the lung, and then you've got another issue. You've got a pulmonary emboli. So pallor, cyanosis, and heart failure may be caused by pulmonary emboli. Be alert to these situations. Sudden cardiac death is usually preceded by VTAC. I know you saw a strip of that in chapter 33. Just looks like a big old up, down, sawtooth, right? Ventricular fibrillation, it's just a wiggly line. And those are very deadly rhythms because VTAC will shortly turn into VFib and then it will go asystole or straight line. Another thing that can happen is ventricular aneurysm and rupture. So weakened areas of the ventricular wall may bulge during contraction, and when that ventricle squeezes, it can rupture. And that is not good. All right, let's move on to the next chapter, next information. Signs and symptoms of an MI. Classic symptom, MI. It can radiate down the arms, the back, the neck, or the jaw. Lasts more than 20 minutes. The patient may be diaphoretic, lightheaded, have nausea, vomiting, and dyspnea. Women may report more vague symptoms. Usually have an anxiety and a feeling of impending doom. I had a friend whose mother had a history of a heart surgery, and she went to the emergency room because she had nausea and vomiting. Well, they admitted her to the hospital, but they didn't put her on a monitor because that was an unusual sign, nausea and vomiting. They didn't put her on a heart monitor. Guess what happened? She passed away in the night. No one was thinking of heart. So medical diagnosis. So this is one of the labs that I wanted you to learn about. Really, really important. A troponin. Troponin is the protein released with heart damage. And back in the old days, my days, we used to look at the CK enzymes and the myoglobin, but we found those were just muscle. Troponin is specific to heart damage, not just muscle. I know the heart is a muscle, but we want specific labs to the heart damage. So that's your troponin. EKG will show ST elevation or inverted T waves. Now that is in your book on page 643, but I think I have a picture of it for you. Yes, indeed. Here it is, because it's important. So EKG changes with myocardial infarction or ischemia. So you'll have an inverted T wave. Remember, we normally have an upright T wave. Remember how that normal PQRST looks? Think about it. If that T wave doesn't go up and it goes down, that could be a sign of ischemia. Also, an ST elevation. Look at that. What's happening here is that the T wave has risen all the way up to the R wave, that point. It's risen all the way up. So you have an ST elevation, and that's really important to know. Then another thing that can happen is the Q wave. So usually it's a P, Q, R, S. The R is the very top. The R wave comes after the P wave. In this case, the Q wave goes way down. It's greater than 1/3 of the height of the R wave, and that indicates necrosis through the entire wall, or transmural. And that is on page 643. So what are some drug therapies that we can use for our patients having an MI? Nitroglycerin IV is really good. It dilates coronary arteries and increases blood flow to damaged areas. Now, I know we talked about taking nitroglycerin sublingually, and that's for chest pain. But right now, we've got injury. So we want nitroglycerin IV. And of course, that would be on an infusion pump, and the patient would either be in the ER or sent up to the ICU, the cardiac ICU. Morphine can be given, and that causes decreased blood flow returning to the heart. That doesn't sound right. Okay, so morphine causes peripheral pooling of blood, which decreases the blood returning to the heart and lungs. So, yes, it's right, but it does it in such a way that it puts less work on the heart by reducing blood flow to the heart. Also, morphine also diminishes anxiety, decreasing tachycardia, and relaxes bronchial muscles. That improves its gas exchange. Of course, this patient should be on oxygen above 90% to assist in oxygenating myocardial cells. Fibrinolytics, now those were in Chapter 33, like TPA and streptokinase. Those are given IV. They dissolve thrombus. They're called clot busters. They dissolve the thrombus. Nothing does it like a TPA or streptokinase. Criteria is that there's no recent surgery, no active bleeding, no history of a stroke, no bleeding disorders, and they should get an informed consent, because this is pretty heavy-duty medication. And it hasn't been going on that long. I can remember when I worked in Manteca's when we first started giving it, and it was an amazing drug because it can dissolve those clots right away. Unlike preventing them from expanding, it will actually dissolve them. And then heparin would be used after that to prevent further clot formation. So after the TPA is infused, they would be put on a heparin drip. So I just wanted to show you a picture of another form of treatment, and that's the PTCA, the percutaneous transluminal stent, coronary angiogram. So this particular picture shows you it's gone in through the femoral artery, goes up into the coronary artery, and it finds the plaque. Then it just goes in between the plaque and opens up and pushes that plaque against the wall. Now you can imagine they're going to have to do that slowly because they don't want to push through the wall. but they want to push that plaque, flatten it out, and hold it open. Hold that area open so they can get good blood flow to the coronary arteries. So that is called PTCA. It's pretty amazing. It stays in place, looks like a little fence almost. It stays in place. The blood can flow right through it because it just holds the plaque open, and blood flows through. Sorry. And then sometimes, though, it doesn't always work, and they might have to be re-stented. So watch for that. If they do continue to have chest pain, maybe their stent stopped working or collapsed. Also, sometimes it needs to be re-stented every 5 years or so. Another thing that could happen after an MI, and after they've gone in with maybe a coronary angiogram and looked at the coronary arteries that were blocked, and they found some major coronary arteries. I just wanted to show you a picture of the coronary bypass graft. Now, I know you have this in your book on page 645. What they have to do here is they have to stop the heart. And they'll stop that heart and open up the chest. First, they open up the chest, stop the heart, put the patient on the heart-lung machine, and then they will sew either their some arteries. I'm going to go into this a little bit more a little bit later, but they take either the mammary gland, mammary artery, or a saphenous vein graft, and they sew that and bypass the occlusion so they can get good blood flow. And notice that that left internal mammary artery is attached to the left subclavian artery. So that is direct off of the aorta, right from the heart. So it's nice, fresh blood. Now, if they did have to take the saphenous vein, they do have to open up the leg, take out the saphenous vein, and they turn it upside down because remember, veins have valves in them. Well, they don't want the valves stopping the heart, so they turn it upside down so that the valves face down and that there's no, they don't obstruct the flow into the heart. So how do we care for that patient after their MI? Well, I've got a good little mnemonic for you, and it is in your book. It's called PQRST. So P is precipitating factors. Now this is in your book, page 646. Precipitating factors. What was the patient doing when the pain began? Were they active or not active? What's the quality of their pain? Have them describe it in their own words. Now again, it might not be 0 through 10. It could be, felt like an elephant sitting on my chest. Was it stabbing? Was it burning? That's the quality. The region, where's the pain located? Is it down your arm, up your jaw, anywhere else? How about the region or the radiation? Where's the pain located? S, severity. Have the patient rate the pain 0 to 10. And like I said, they don't always know a number, but they can give you the amount of weight that it feels like the elephant or like the armadillo sitting on your chest, or the dog sitting on your chest, or a kitty cat sitting on your chest. Kind of gives you a visual of how severe their symptoms are. And then T is for time. When did the pain start? How long ago did it start? How long did it last? Record what the patient was doing when the pain started, what action was taken, and the effects of any actions or treatments. You also want to inspect the patient's skin for color and palpate for temperature and moisture. Assess their vital signs. and document the patient's mental status as well as everything else that we were just talking about and their level of anxiety. When cardiac monitor is initiated, evaluate the rate and rhythm. And remember, I had also said not only the rate and rhythm, but is there a P, then a QRS, and a T? How does it look? All right, so under interventions, we have pain. So morphine can be used in small amounts intravenously every few minutes to help the pain be relieved. Remember, that's a vasodilator. And if the O2 saturation is 90 or below, they might need oxygen, but morphine will also help get them oxygenated blood with that vasodilation and perfusion into the lungs. The head of the bed should be elevated about 30 degrees. Then another thing, inadequate circulation. So watch the EKG for changes from the normal waveform and for dysrhythmias. So it's important, again, that you know what a normal EKG looks like so that you know if there's a change. Is the PR interval normal or getting longer? Or did they drop a beat? Or is there an early beat? Or is their T wave peaked again? So need to notice that. I know if you plan on going into telemetry or to the ICU, you'll get extra training about this, but it's good for you to know these basics. So again, the patient might exhibit some anxiety, so be sure to provide a calm environment, and that includes the family, because sometimes the family can be excitable because the patient's on drugs by now. So keep the patient and the family calm, and that's with your therapeutic communication, and that is with your level of professionalism and calmness that you're going to talk to the patient. And then cardiac rehab. So that involves patient teaching. And I want you to look at that box, a patient teaching box over on page 647. And it talks about it is very important to take your medications. So this is your teaching the patient. This is after the fact. You're teaching them to contact their health provider if they have any problems. And, they can keep track of their drugs. They can keep track of how they react to the drugs, how they feel. They're probably taking their blood pressure because of the drugs that they're on. Also, they need to keep their appointments. Now, I know that's not in this teaching blurb here, but just know that they also need to keep their appointments. The healthcare provider will prescribe a low-fat diet, decrease weight, and reduce the workload on the heart. Stop smoking. That keeps coming up, doesn't it? Because why? Smoking's a vasoconstrictor, and we don't want that when we're dealing with the heart, or blood pressure for that matter. So let's go on to the next slide. Before we go on to heart failure, I can go ahead. Let's just talk about heart failure. So heart failure is the inability of the heart to meet the metabolic demands of the body. The pumping ability of the heart is ineffective. What are cause and risk factors? Well, symptoms seen when the heart fails to pump effectively and blood backed up into the vasculature of the lungs, producing congestion. So you might have breathing problems, right? So there's two terms, heart failure and congestive heart failure, and it can be used interchangeably. The causes of heart failure are of two types, and that's disorders that increase the workload of the heart and disorders that interfere with the pumping ability of the heart. So let's look at some pathophysiology. So with heart failure, the left ventricle, now picture the heart, you've got your right side and your left side. We're talking about the left ventricle. So with heart failure, the left ventricle, right ventricle, right above it, or both ventricles fail as a pump. Usually the left side of the heart fails first, and then in time the right side fails as a result of left-sided failure. So compensation. Compensation is a term used to describe the cardiac and circulatory adjustments that maintain or restore cardiac output to normal or near normal. So there's different types of compensation. There's a sympathetic compensation, where the sympathetic nervous system responds to decreased cardiac output. Catecholamines are released to increase the heart rate, stroke volume, cardiac output, and venous tone. Then there's renal compensation. The second mechanism that responds to decreased cardiac output is renal compensation. When renal cardiac output falls, so does renal perfusion. So this is where that renin-angiotensin-aldosterone mechanism comes in. Renin is secreted by the kidneys and activates angiotensin. Angiotensin 1 converted to angiotensin 2, which causes vasoconstriction and triggers the release of aldosterone, and that will increase the blood pressure. Aldosterone causes the kidneys to retain sodium and water, which increases blood volume. Then there's ventricular hypertrophy, which is afterload. Afterload increases with left-sided heart failure. Blood backs up into the left atrium and then into the pulmonary veins. So that's when you start getting that pulmonary congestion. Because of the high pressure in the pulmonary veins, fluid leaks into the capillaries, into the interstitial space in alveoli, causing pulmonary edema. So remember, left-sided failure backs the blood up into the lungs, and that's when you get the lung symptoms, the pulmonary edema. Also, you can get pulmonary hypertension that will eventually be caused from constant pulmonary edema and back up into the pulmonary system. And then that could cause right-sided failure because the right side goes into the pulmonary system, right? So if you can't go into the pulmonary system because of hypertension and pulmonary edema, then the right side begins to back up. And what are the symptoms of right heart-sided failure? You get your JVD. You get your decreased urine output. You get your pedal edema. So JVD, decreased urine output, pedal edema. That would be your right-sided failure. In some of the labs in Chapter 33, it talked about ANP and BNP. Atrial natriuretic peptide is ANP, and that's released in response to increased volume and stretch in the atria. That might be a lab test that is done. A BNP is a blood test that shows the cardiac ventricles are stretched, and that will show heart failure. So if they suspect heart failure, they will draw a BNP. Signs and symptoms with left-sided failure. Now left, go to left. Anxious, pale, weak, and tachycardic. And as I said, it goes into the lungs, backs into the lungs when that left side fails. So you get crackles, wheezes, dyspnea, and cough. When assessing heart sounds, you're going to hear the S3 and S4 because of the backup of fluid and the heart's inability to handle it. With right-sided failure then, again, you get the JVD, abdominal engorgement, and dependent edema. Didn't mention the urine output here, but that is one of the things they have as well. Medical diagnosis, so certain lab tests are drawn. Like I said, they'll do the BUN. They want to see how the urine is working, how the kidneys are working. The BNP for heart failure. They want to check liver functions to see if those are elevated because that liver's on the right side, so maybe there's some hepatomegaly, enlargement of the liver as well. Medical treatment. Drug therapy is to improve cardiac output and eliminate excess fluid. So what do we need there? Well, it sounds like a diuretic, doesn't it? Maybe Lasix. What improves cardiac output? Maybe digoxin. Increase cardiac output. Slows and strengthens the heart. Of course, it's always the doctor who decides what to give. Sodium restriction for the patients with heart failure. We used to put our patients on 2 gram or 2,000 milligram sodium diet, and that's not a lot. Drug therapy, ACE inhibitors. So remember, ACE inhibitors prevent angiotensin II that narrows the blood vessels. So blood vessels relax, so it's an ACE inhibitor. The blood vessels relax and widen. ACE inhibitors. That's the pines. Is that the pines? All right. Then we also have digoxin, a cardiac glycoside, which inotropic effects. Inotropy again means force of contraction. So it increases their force of contraction. Improves the pump. Nitrates, such as nitroglycerin and vasodilators, that reduce preload for patients with heart failure. So we know nitroglycerin's a vasodilator. Then morphine also may be prescribed, decreases anxiety and dilates vasculature, and decreases myocardial oxygen. Some complications. Complications would be dysrhythmias, pulmonary edema, renal failure, and cardiogenic shock. Those all have to be treated individually with different medications. And then what is the nursing care? That's our job, right? So we want to assess their heart sounds. So remember those heart sound places, positions that you learned about. That's where you can hear any kind of murmurs that the patient might have. So you also want to look at their rate and rhythm, or listen to their rate and rhythm. So a PMI. Now that might be something that would come up in NCLEX. It means point of maximal impulse. And it should be noted with the apical and radial pulses. So you can assess them both. Listen to the heart and check the pulse. Check for JVD. Respirations, their rate, rhythm, and breath sounds is important. At some point you need to check their weight and blood pressure and inspect their skin turgor and edema, their INO, keep track of that because they might be on diuretics, so we want to be sure that they're putting a lot out more than they're taking in to get rid of that extra fluid that they've accumulated. Okay, so those are some things that we want to do with our focused assessment. And then we want to also check our patient's sign of digitoxicity. The thing about the older patient, and they do draw dig levels, so the doctor may order a digoxin level blood test, maybe monthly or every couple months, for a patient on digoxin. Now, the older patient doesn't have as much albumin, and digoxin is albumin binding. So if there is not enough albumin for digoxin to bind, there's a lot of free-floating digoxin, and then they can get toxic from that. And that would really slow their heart down. Signs of digitoxicity would be anorexia, nausea, visual disturbances. Bed rest and stress reduction reduce or decrease the cardiac workload. Give partial baths. We don't want to work them out too much, cause too much stress, too much activity. So change their position every 2 hours, partial bed bath, and visitors should be limited, and advise them to be quiet with the patient. So I want you to remember, and it says so in this pharmacology capsule, before each dose of digoxin, the apical pulse is counted for 1 full minute. If the heart rate is less than 60, the drug is withheld. You put it on hold. You don't give it, and it may say to hold it if it's less than 60, whatever the doctor's said, he may say hold it if it's under 60, so you'll hold it, and then the next day if you have to hold it again, you'll have to notify your healthcare provider, because that's too many days to hold it. The most common cause and effect of diuretic therapy are fluid and electrolyte imbalances. So be sure you check their labs, check their potassium, because that's what lowers with diuretic therapy. Inadequate oxygenation. Hypoxia is a common finding with heart failure because of pulmonary edema. So they've got so much fluid they can't oxygenate very well. And this occurs with right-sided heart failure because of decreased flow to the lungs. The patient with heart failure usually breathes easier in a semi-Fowler position. Elevate their head, check their O2 saturation, and their oxygen flow. Increased fluid volume. Fluid retention is a response to heart failure. Unfortunately, it compounds the problem by increasing the workload of the heart. So you'll have to do measures to reduce the fluid volume, administer diuretics as ordered, and monitor the patient for adverse effects. So be sure you notice if their potassium is low. Do they need diuretics? Are they edematous? And they're not on diuretics, but they're edematous. You need to let the doctor know so that he can order a diuretic. An IV catheter is usually placed to provide a route for drug and fluid administration. If IV fluids are administered, monitor the rate of administration very carefully and watch for fluid overload. And that would be fluid in the lungs, edema, trouble breathing. Be sure their I&O. Check their I&O. So sometimes the fluids need to be restricted that the patient can have. And that's hard because patients are always thirsty, especially if they're on a diuretic. So give them some small containers, offer them fluids at small intervals. Be sure you let the family know, though, because when you walk out of the room, they may very well turn around and give the patient a lot to drink, and you don't know. So be sure you keep an eye on that. Another thing is sodium restriction. Reducing sodium intake reduces the workload of the heart by reducing the amount of fluid they retain. Another thing is inadequate mobility, so they need to be on bed rest. We need to decrease the amount of activities that they have because it puts too much workload on the heart. I hope you're still with me on page 651. Also, the patient may suffer from some anxiety because they might feel short of breath. They're in unfamiliar surroundings and different routines. You know, in facilities, it's 24/7 that we work. And they don't know what's going to be happening to them, so they're scared. So be sure that we relieve their anxiety. All right, let's move on. Here again is some medical treatment for heart failure. ACE inhibitor, I'm repeating these things for you, so I hope that this makes it clearer. ACE inhibitor limits the progression of ventricular remodeling. In other words, I'm going to show you a picture of heart failure muscle, and we don't want that muscle to become too thick so that it doesn't work so well. Diuretics decrease circulating volume in the heart. Beta blockers decrease heart rate and reduce oxygen demand. And remember, we don't ever stop beta blockers. We can hold a beta blocker because of the heart rate or blood pressure, but we never want to just stop them altogether for a period of time. Inotropic agents, dopamine, IV for short-term management of contractility. Cardiac glycosides like digoxin increase contractility and slows heart rate. Nitrates are vasodilators that reduce preload. So by dilating the blood vessels, they're decreasing the amount of blood that comes into the heart and increases the amount of blood that does not stay in the heart. Morphine reduces anxiety and oxygen demand. And again, just repeat, nursing care of the patient with heart failure. You want to assess them. You want to do your interventions, decrease their fluids, salt intake. Be sure they have adequate oxygenation. They're on oxygen in a semi-Fowler's position. Be checking their O2 sat, listening to their lungs for any heart sounds or lung sounds, crackles, wheezes. We will see increased fluid volume, and that would be our diuretics we want to give, and checking of the pedal edema and the lung sounds. Keep them at rest for their mobility, not doing too many activities, and relieve their anxiety. Right, we're going to move to cardiomyopathy, and that's on page 651. So cardiomyopathy is going to be, we're going to use the initial CMP. Okay, so when you see that in your book, it's cardiomyopathy. So CMP is disease of the heart muscle, maybe secondary to another disease process. The disease usually leads to heart failure. There's 3 types of cardiomyopathy: dilated cardiomyopathy, hypertrophic, and restrictive. Dilated cardiomyopathy is the most common type, and it exists in cases like ischemia, hypertension, alcohol or drug abuse, infections, chemotherapy in pregnancy, and genetics. Hypertrophic cardiomyopathy is often genetic and is the most common inherited heart defect. Many athletes who die suddenly are found to have hypertrophic cardiomyopathy. Sometimes we hear of basketball players or football players just collapsing and dying. Could be they have a condition of cardiomyopathy. And then there's restrictive cardiomyopathy, the least common type, and that's usually caused by amyloidosis, sarcoidosis, or other immunosuppressive disorders that may predispose individuals to restrictive cardiomyopathies. So let's look at some pictures here. So this is a normal heart, and you can see the left ventricles, the aorta, left atrium. So here's your dilated cardiomyopathy. See how the ventricles are dilated? And that's caused by ischemia, hypertension, alcohol or drug abuse, infections, chemotherapy, pregnancy, and genetics. Then there's the hypertrophic cardiomyopathy. Look at how thick that blue is. And look how little the left ventricles are. This is the most common inherited. Many young athletes who die suddenly are found to have the hypertrophic cardiomyopathy. Now, would this show up in a chest x-ray? It might. It might. The restrictive cardiomyopathy is the least common, caused by amyloidosis, sarcoidosis, immunosuppressive disorders. So, nursing care of the patient with cardiomyopathy. These patients are primarily assessed for heart failure because their pump's not working. Be alert for dyspnea, cough, edema, dysrhythmias, and decreased cardiac output. What interventions are we going to do? Well, they're similar to that of heart failure. Encourage the family to support the patient. Teaching plan guides the patient to make lifestyle changes. Increasing knowledge about the disease is often empowering. Okay. Let's go to cardiac transplant. What if the patient gets so bad? Their heart's not pumping at all. Their heart failure is worsened. Their cardiomyopathy is bad. They have no pump left ventricular oomph from their heart. So the donor must meet the criteria for brain death. That's the donor. The donor must have no malignancies outside the central nervous system, be free of infection, and not have experienced severe chest trauma. So these could be patients not with disease. It would have to be someone involved in an accident without severe chest trauma, though. Aftercare is similar to that of coronary artery bypass surgery. Patients and families are taught signs and symptoms of infection to avoid crowds and others with infections. They need to be on lifelong immunosuppression. Now, there is a network that keeps track of people that need hearts on a heart transplant list. It's called UNOS, and that's called the United Network for Organ Sharing. There's one for heart, there's one for kidneys, there's one for liver. So patients are put on this according to their need. How bad are they that they need a heart transplant? And just remember, it needs to be a good size, about the same size as the patient. So we don't want to put an adult's heart in a child or a child's heart in an adult. We do need to keep the patient, the donor, on life support until they're ready to take the heart. So that's why we need to let the doctor know right away. If there is a patient that has an available heart, they do have to have brain death, and let the doctor know right away. The patient needs to be on the hemodynamic monitoring, ventilation, and after the transplant, that patient will be on hemodynamic monitoring, mechanical ventilation. They might have chest tubes, need to keep I&O, accurate I&O. Might be in a special room. You might have to wear gowns and masks. Transplantation, they're immunosuppressed, and they're on lifelong immunosuppression, so they need to be protected. You might need to wear a mask. They might need to wear a mask when they go out. Pulmonary infections are most frequently found after heart transplant. Okay, so let's go to the next thing. So I just want to show you a picture of what a transplant would look like. So, they have to take the whole heart out. So after the recipient is placed on cardiopulmonary bypass, the heart is removed. The posterior walls of the recipient's left and right atria are left, and that's the blue. The left atrium of the donor heart is anastomosed or sewed to the recipient's residual posterior atrial walls and the other atrial walls. Atrial septum and the great vessels are joined. So here's the result. After the recipient is placed on cardiopulmonary bypass, the heart is removed. Posterior walls of the recipient's left and right atria are left intact. The left atrium of the donor heart's anastomosed the recipient's residual posterior atrial walls and other atrial walls. And the atrial septum and the great vessels are joined. This is quite a job for a surgeon to do. So let's talk about inflammatory disorders. So an inflammatory disorder is inflammation of the heart, most often results from systemic infections. The endocardium, myocardium, and pericardium may be affected. So the first thing I have here is infective endocarditis. The cause and risk factors for that would be organisms present in the blood, that easily colonize on the valves, damaged by rheumatic heart disease or congenital effects, or a mitral valve that is prolapsed. So these little veggies attach themselves to the heart. The problem has increased in IV drug users. And I had a patient with infective endocarditis, and she had a direct route, an IV, into her. So she's a drug user. That's how she got into this position. So be sure you keep an eye on these patients because they have easy access to drug abuse. So don't let them close the curtains or go in the bathroom and lock the door. Keep an eye on them. Patients with known valvular disease are also at risk for inflammatory endocarditis, infection endocarditis. They should be treated with prophylactic antibiotics during dental or invasive procedures. If they have a known valve disorder, they need to be placed on prophylactic antibiotics. So let's say you're going to go for dental work. You might need prophylactic antibiotics so that you don't get an infection. Pathophysiology. Pathogens, and usually bacteria, enter the bloodstream by any of the previously mentioned means. The pathogen accumulates on the heart valves. For some reason, it goes to the valves. The endocardium, or both, and forms vegetation. I call them veggies because they can be like a fungus ball, a veggie ball. The mitral valve is the most common site for vegetation. The turbulence of the blood flow through the heart weakens the vegetation and causes pieces to break off. That's why it's so important to get them on IV antibiotics right away. We don't want fungus balls floating around or to other parts of the body. These emboli can obstruct circulation and impair tissue perfusion in the lungs, brain, kidneys, and heart. Complications include heart failure and embolization. Heart failure is the most frequent cause of death with infective endocarditis. Signs and symptoms they'll present because they have an infection with fever, chills, malaise, fatigue, and heart and weight loss. Chest or abdominal pain may be reported, possibly indicating embolization. So if you notice something besides just the chest hurting, it's possible an emboli broke off and went to another part of the body. They can microembolize and cause petechiae. So you might see petechiae throughout the body. Arms, legs, feet, ankles, antecubitus, mouth. They're pea-sized, tender, red to purple lesions, known as ossular nodules, maybe on the patient's fingertips or toes. They might have flat, red, painless spots noted on their palms and soles. Medical diagnosis based on the history, physical, results of lab studies, so if their white count's elevated, maybe some blood cultures. Auscultation may reveal a heart murmur. Echocardiogram helps to visualize vegetation. Remember, echo, especially TEE, can look at the valves. That can help to visualize vegetation and valvular regurgitation. And then the serial blood cultures may give clues to the organism. So a blood culture, a culture we get a specimen, do a culture, and then we find what antibiotic is sensitive to that culture or that growth, that bacteria. So the WBC might be elevated. Medical treatment, antimicrobial drugs, whatever the culture and sensitivity would show, rest, limitation of activities. Antimicrobials are given IV for 2 to 6 weeks. This is a condition where we really need to get rid of that infection. So IVs for 2 to 6 weeks, depending on the organism. Now they can go home and get this. Maybe home health can come in, or sometimes they'll train a significant other to give the antibiotics. Or they might go to rehab if they don't have anybody. And then an IV nurse can give it to them at the facility. Prophylactic anticoagulants may be necessary also to thin the blood, also to reduce the fact that if that emboli does get loose, it's not going to get stuck somewhere because they're on a blood thinner. Surgery may be necessary to replace an infected valve if they can't get rid of that infection, or if it seems to be getting larger, or if the valve is not working properly and endangers the person's life. They might need surgery. So nursing care of the patient with infective endocarditis. So review their risk factors. Are they a drug abuser, or how did this happen? Did they have any recent invasive procedures that maybe infected them with a bacteria? Any known pathologic cardiac conditions? When did the symptoms start? Is their temperature elevated? Do they have a murmur? It's good to learn your murmurs. So interventions. Administer antibiotics as prescribed. It's important to continue to assess cardiac output, and that would be your blood pressure, and monitor for complications. Teach the patient about the medications prescribed and why it's so important to take them, why it's so important for them to get these antibiotics. Next thing is pericarditis. So that's the pericardium. It's the inflammation of the pericardium and can be a primary disease or associated with another inflammatory process. The disease may be acute or chronic. Viruses, bacteria, fungus, trauma, or MI can cause acute pericarditis. Sometimes I would see patients after heart surgery get a pericarditis, inflammation of the pericardium, because they had to open the heart and the sac around the heart, so that fluid was absorbed by the body. So when they closed the heart up, that pericardium didn't have the fluid in it. So the body makes the fluid, but it may take a few days. So the patient might experience a pericardial friction rub that's very painful, presents like chest pain. So sometimes anti-inflammatories help with that because it is an inflammation. So listen for that. It'll sound like a squeaky noise, like a ree, ree, when you listen to the heart sound. Pathophysiology, the fluid, like I was saying, inflammation of the pericardial membranes. Sometimes it's from scarring. They get a loss of elasticity that results from scarring. This constrictive process prevents adequate ventricular filling. It prevents adequate ventricular filling. Complications. So the major complication of pericarditis is pericardial effusion or accumulation of fluid. So maybe they have too much fluid now in the pericardial space. And this can lead to cardiac tamponade, which means it just gets so much fluid in there that the heart can't function. The resulting drop in cardiac output is an emergency. It's treated with a pericardial centesis, so the doctor will have to put a needle in and take out extra fluid in the pericardium. Chest pain is the hallmark symptom of pericarditis. Now, what's interesting about this is the pain is most severe on inspiration, so we don't want to confuse this with chest pain. First of all, we've got probably the rub, the friction rub. The pain may be relieved by sitting up and leaning forward because they've moved the heart a little bit. Dyspnea, chills, and fever might accompany a pericarditis. ST segment elevation may be noted on EKG. You will hear a pericardial rub. That sound, squeaky sound, because it's the heart rubbing against the pericardium. A slowly progressing pericardial effusion creates hemodynamic compromise. Now, I had a friend who was on chemotherapy, and she developed a pericardial effusion, and they had to put in a window into her pericardium to allow for that fluid that had accumulated there so it wouldn't restrict the heart. All right, so let's read on. So like I was saying, under medical diagnosis, the differentiating factor to consider is that position change does not relieve ischemic chest pain or angina, but it will relieve pericarditis pain. So yes, they both present like chest pain, but change the position, because that's not going to go away with heart pain or coronary pain, but it will go away with pericardial pain. Treatment: analgesics, antipyretics, anti-inflammatories, and antibiotics. The pericardial centesis to remove accumulated fluid. or the surgical creation of the pericardial window, like I was explaining, that allows for the pericardium not to be restricted and can allow for drainage of pericardial fluid. Okay, how about nursing care? Well, with pericarditis, assessment of heart sounds is especially important. Rest and reduction of activity decrease the workload of the heart. Administer medications and teach the patient about them. Emotional support, monitor their vital signs, auscultate for that friction rub. And that rub is usually heard during inspiration with the diaphragm of the stethoscope placed over the second and fourth intercostal spaces. This, folks, is why we learned our heart sounds. The rub is heard when no fluid accumulation is present, and distant heart sounds may be heard when fluid accumulation exists. So let's talk about valves now. Valvular disease. So how many valves do we have? 4. So that means we got like 8 heart problems. All right, so we can have mitral stenosis. Mitral stenosis is a narrowing. Anytime I say stenosis, that means a narrowing of the opening. So where's the mitral valve? I'll give you time to think about it. It's between the left atrium and left ventricle. The mitral valve leaflets become thick and fibrotic. I think that I'm going to go on because I believe I have some slides here. So, mitral stenosis impedes blood flow from the left atrium to left ventricle. The murmur is rumbling and low-pitched. Ooh, I made a few typos on this one. Sorry. Rheumatic heart disease is the leading cause. So it's interesting as I talk about all these valve diseases, a lot of them are rheumatic heart disease causes. Now, we don't have rheumatic heart disease here in the United States, but when I worked down in Los Angeles at Cedars-Sinai, we got a lot of Jewish people because it is a Jewish hospital. So we would get Jewish people from Europe. They don't get treated for rheumatic heart disease or rheumatic fever. So they develop rheumatic heart disease. So we had a lot of valve replacements at that hospital, and they were free to charge for these patients because it was a Jewish hospital. They took Jewish patients for free. So a lot of valve replacements. So when I say rheumatic heart disease, know that it's usually someone from another country. Rheumatic heart disease leading cause, signs, and there's another typo. Must have been getting tired. Signs and symptoms are dyspnea, fatigue, cough, chest pain, activity intolerance. It could be diagnosed by an echocardiogram or that TEE, transesophageal echo, that always looks at valves. Medical treatment, drug therapy, fluid restriction. And surgical treatment is commiserotomy. So what a commiserotomy is, because it's stenotic and the opening is not very big, they'll just open it up a little bit. So that's a commiserotomy. When I say MVR, that's mitral valve replacement. So they'll replace the mitral valve. Or balloon valvuloplasty. So because it's stenotic, they'll put a balloon in there and open it up. That's another treatment. Mitral regurgitation. So that allows blood to flow back into the left atrium during diastole. Murmur is high-pitched and blowing. Typo. Atrial fibrillation may occur. Medical treatment includes vasodilators to decrease afterload. They may need an annuloplasty. Again, that's an opening. A closing, open to close, tighter, because right now it's flopping around. So they're going to fix the annula or the opening of the mitral valve. or they might even have to do a mitral valve replacement. Mitral valve prolapse. So one or both leaflets enlarge and protrude into the left atrium during systole. It tends to run in families. Again, rheumatic fever can cause mitral valves to be diseased, or even congenital abnormalities. In most patients, symptoms do not occur, but it may be found on a cardiac echo. Stress reduction techniques are important for mitral valve prolapse. That means they need to do that meditation or just do some relaxation to decrease stress, because it can cause more problems with a mitral valve prolapse. Then there's aortic stenosis. That may be caused by congenital malformation, rheumatic fever, syphilis, or more commonly just in the aging population. Another typo. Systolic murmur. What's DOE? Dyspnea on exertion. The left ventricle hypertrophies to compensate for delivering a strong atrial kick. This compensatory mechanism allows normal function and until atrial fibrillation interrupts, or until the left ventricle hypertrophies to the point of decreased cardiac output and possibly even an MI. If not corrected, it leads to right heart failure. You would treat aortic stenosis with diuretics, activity restriction, possibly a balloon valvuloplasty, so the balloon will open the area, open up the valve, or an aortic valve replacement. Now we have aortic regurgitation, caused primarily by rheumatic fever again. The murmur of aortic regurgitation is high-pitched and blowing. Regurgitation into the left ventricle during diastole increases blood in the left ventricle. MI and left ventricular failure can occur. You might see a widened pulse pressure. Be sure you know what pulse pressure is, and that is an increase between the systolic and diastolic pressure. So it may be 120 over 80, then it goes to 120 over 70. That's increasing pressure, pulse pressure. Treatment for aortic regurgitation, it could be digoxin, diuretics, or an aortic valve replacement. So here I just have a picture of some valves. These are mechanical valves. In the very beginning, they used pig valves. So that was interesting, because what if you were allergic to pork? You couldn't have a pig valve. But now they came out with mechanical ones. So this is a type of valve. You can see these are kind of the leaflets in the middle there. Here's another type of valve replacement. These are in your book, by the way. And that's a freestyle valve. Different companies make valves for replacement. You can kind of see the leaflets inside. And the doctor will sew that into, they take out the old yucky valve and put in the new valve. Also the metal ones, they make a real clicky sound. And in the beginning, we had the ball and socket type of valves. So there was a ball inside of a cage, and it would click, 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 click. You could hear it across the room. Well, they quickly did away with those and went to these more real type of valves or man-made type of valves. Here's another type of valve. These pictures are in your book, so you can have a peek at these. So I want to take a moment to talk about the care of the patient. Just be sure that you're always assessing their vital signs and heart sounds, their I and O. Document any arrhythmia If they have a widened pulse pressure, you want to note that.